Yeah.
Good afternoon, Doctor. Now we are with Instruction Course 6, and I would like to welcome Dr. Raman. Over to you, sir.
Hello.
Yes, sir, you're audible.
Audio. No, Vasha?
Yes, sir, you're audible.
Am I audible?
Yes, sir, you're audible. We would like to welcome you for the session, sir. Please take over.
Can I begin the session?
Yes, please, sir.
Yeah. So I welcome my co-speakers, Dr. Ramesh and Dr. B. Rao, and my colleagues, Dr. Kishore, Anjali Chandrasekharan, and Dr. Darakshan for this TAS instruction course. And I am very thankful to the TAS Management Committee as well as the Scientific Committee for giving this opportunity. So my presentation is on the pearls in the management of childhood triangular palsy. Next.
Yes.
No. So this case is a complete triangular palsy in the child, where the clinical picture itself speaks the diagnosis with a hypertrophic eye with gross ptosis and exotrophy. And second case, here this is a case poses a lot of diagnostic problem. Okay, so there is an exodeviation in the right eye. So in these cases, if you utilize the dog's head maneuver by rotating the head to the right and as well as to the left, we see the full range of movements. So that excludes the diagnosis of Charnow palsy. So before establishing the diagnosis of a Charnow palsy, always we should exclude the other palsy. Okay, now am I audible?
Yes, sir. Please go ahead.
Okay. So once we establish the diagnosis of a Charnow palsy, we have to decide whether it is a acquired Charnow palsy or a congenital Charnow palsy, and whether it is a complete Charnow palsy or a partial Charnow palsy. So in a congenital Charnow palsy, usually the most common cause being the intrauterine trauma resulting in hypoxia and resulting in a Charnow hypoplasia or aplasia. And whenever there is a Charnow palsy associated with other CNS abnormality, it has to be taken for the thorough neurological evaluation. And whereas in acquired cases, usually they present around the infancy, I mean second part of the infancy and early childhood. So that is the benchmark for the diagnostic criteria to be taken. And in acquired cases, usually the trauma, birth trauma, and then the space occupying lesions, and then the infections like viral fevers and meningitis and so on, and SOLs, intracranial tumors are the frequent causes. And a neurological investigation has to be done. Particularly, we have to establish whether it is an isolated palsy or a polyneuropathy is there. If there is a polyneuropathy, always we have to specify the area of localization for the interest of doing a neurological investigation. And once the diagnosis is established for a primary cause is established, then it should be referred to a neurologist or a neurophysician. And remaining cases, the Strabismologist, we take care of that. And during the period of recovery time, between 6 to 12 months period of time, so we have to take care of the preemptively, we have to treat the amblyopia, and we have to try to prevent the amblyopia. For that, we do an alternate occlusion, and sometimes we do the chemodenervation, especially given to the left muscle, because it will create a violent contractions, especially in case of Charnow palsy. So once that period is over, once the deviation becomes stable, then we have to re-examine the cases carefully, and we have to customize the surgical treatments as per the need. So let us move on to the case space. Yeah, here is a case. A 3-year-old female child presented us with gross head tilt and turn to the right, and a gross exodeviation in the left eye. And on alternate cover test, there was a free alternation was there, and there was an adduction limitation in the left eye. This case was taken for supramaximal lesion of 14 mm in the left eye and 8 mm of resection. So postoperatively, you can notice here good orthotropy achieved, and FDT was negative, and MR muscle you can notice here a flaccid muscle. You can see it, a weak flaccid muscle. So these are the postoperative results. CSP is completely neutralized. Then the second case I'm presenting here. This is a patient showing Marcus gun jaw winking phenomena and a hypertropia with little bit of exotropia with -1 adduction limitation with pseudotosis and two-tosis component. So for this patient, we did a partial NAPS procedure where lateral rectus muscle is transposed obeying the spiral of Tillax, and we applied a fastest augmenting suture, 50 edge-band suture applied here, and these are the postoperative results. And later on, the oculoplastic surgeon did the ptosis correction. It resulted in excellent outcome. Next, this is the third case where a female child presented to us with basically a pseudotosis with hyperdeviation. So cover test establishes that it is a pseudotosis. Here, FDT was done on table and FDT was positive. IR restriction was done, and it was combined with IR restriction. We did a partial NAPS procedure. Again, a full tendon LR is transposed to the superior rectus muscle. And postoperatively, we achieved almost, the ptosis disappeared, and we achieved the orthotropia. So, this is another patient. You can see here in a childhood, neglected child, and in the adulthood, she has presented to us with large exodeviation in the left eye and minus limitation of adduction, where we did a supramaximum lesion resection, and which has resulted in orthotropia. But we cannot achieve the binocular single vision. So the take-home message here is that all pediatric cases have to be meticulously examined, and we have to preemptively treat the amblyopia, and we have to treat the amblyopia and prevent the amblyopia. And as far as the compensated head pressure is concerned, we have to take care of that in the pediatric age group as early as possible. So with this, and the other thing is for complete turnover palsy, the outcomes are not encouraging, but the partial turnover palsy really the results are very good, and most of the times the optimal results we can achieve, and we can treat the CSP, suppose if they are treated in time. So with this I conclude, and I invite Dr. Ramesh to proceed on. Thank you very much for patient hearing.
Very good afternoon, everyone. Dr. Raman, thank you for this opportunity. I'll be talking about nystagmus in general. I'm talking about only the approach today because it's a very long talk. So with this, I'm going to share a 6.5 minutes video which tells us how do we really approach to an nystagmus case, both congenital as well as acquired. So I'll just show this video of 7 minutes.
So there's no audio visible, audio in this.
Okay, I realize that there is no audio. Probably I'll have to give the audio here. So basically, congenital nystagmus is classified into motor as well as sensory. But in recent times, we don't classify it as sensory or motor. But you should know some of the characteristics of the motor nystagmus as well as sensory. Nowadays, they are under infantile nystagmus syndrome. Latent is called fusional maldevelopment nystagmus. You can see that on dampening, on convergence, there is a dampening. On occlusion, you can see the latent part. It's like, this is one more example of nystagmus blockade. When the patient is having that esotropia, there is less waveform of nystagmus. These are all typical sensory because of coloboma, because of disc issues and other things, optic disc issues, you can have this. This is a sensory kind of nystagmus. So direction, and never confuse this with the nystagmoid movement, because usually nystagmoid movements are typically seen in Leber's congenital amaurosis. And these are some of the sensory reasons for nystagmus, either glaucoma or cataract, any kind of lesions. It can cause this kind of sensory part. The latent part is mainly because you can see that on occlusion, you can see that increase in the waveforms, and also their visual acuity decreases. This is fusional maldevelopment nystagmus. This is very, very typical. They can also have nystagmus blockade kind of. See that the nystagmus is increasing. These are all some of the very simple things you need to know with regards to congenital. With regards to acquired, we see spasmus mutans, seesaw nystagmus, and convergence nystagmus, retraction nystagmus. These are typical and downbeat and upbeat nystagmus. When you see these things, you need to always image. 90% of them, they will have something. This is spasmus mutans with the triad of abnormal head posture, head tilt, and also see this head nodding as well as nystagmus here. Typical of that, usually associated with glioma. It's better to kind of image, but there are benign lesions also, and it can also happen in cases of retinal dystrophy. Even vertical nystagmus can happen in retinal dystrophy. This is typical seesaw. Look at the lesions down and up. It's exactly like a seesaw, and it can typically present in chiasmal lesions, either chiasmal tumors or achiasmia. Both the situations you can have seesaw type of nystagmus. Look at this, eyes are convergent. On convergence, there is retraction of the globe also. You can see this on lateral gaze generally, and there is a torsional nystagmus. There can be up gaze limitations. See that on convergence, eye goes back. There is a typical retraction. This happens in two conditions: midbrain tumors, specifically peniuloma and aqueductal stenosis. And the monocular nystagmus of childhood can be there, but it's a benign condition. You can see in this case, the nystagmus is seen only in the left eye. And sometimes you can see a small horizontal nystagmus of the right eye as well. There is a monocular vertical nystagmus also, which can be seen in some of the patients. Specifically in optic nerve glioma and any other optic nerve tumor. This I want you to see very carefully. This is the patient's, I just will go back a minute here. Typical downbeat, it remains for some time, and then the child is okay. Again, a benign condition, no need to really worry in this kind of situations. Downbeat nystagmus, again, one more thing, cervical medullary lesions you need to be searching for. Upbeat nystagmus, generally it is not seen in any of the other conditions, but sometimes you can see typically neurological conditions like cerebellar lesions or even upwards, mid-brain level, you can see this. Typical. Any vertical component, I will image the patient. It's very, very important to really image these patients before you undertake any other procedures or before you check out the patients. You need to ask for imaging. It can rule out Arnold Chiari's malformation. It can rule out syringobulbia. Many of the situations you can rule out. And also remember that nystagmus also can be caused by retinal dystrophy. Albinism and retinal dystrophy are the most common causes of nystagmus in our situation. These are the things I just wanted to show. I cannot cover much part of evaluation and other part of treatment aspect in this video. Probably during the discussion, we can ask for some more discussion points if there is time available. Thank you so much.
I request next speaker, Dr. B. Venkateshwar Rao, to have the talk. Yes, sir.
Yeah, thank you. Thank you, Dr. Raman, to asking me to be a part of this the course for Telangana Ophthalmic Society meeting. And nice talk by both of you, Dr. Ramesha on nystagmus and you on this uncommon conditions like terminal palsy and things. So I'm going to talk to you about Brown syndrome, how you manage and how you diagnose. Now, as you all know, Brown syndrome is basically a mechanical limitation of elevation and adduction. You see here in the left eye is not elevating up, as a result of which this child has the problem looking to the right side. So they tend to adopt a head posture. Now, if you look at this cartoon here, the superior oblique muscle is a unique muscle which goes through the trochlea and inserts onto the globe. So it elongates, when the eye tends to elevate, it elongates up or moves through the trochlea by about 8 millimeters. And when it goes into the field of action of superior oblique, it shortens. So what happens exactly in Brown's is the inability to stretch or inability to elevate the eye is because of the short abnormal tendon. The tendon doesn't elongate as much as it should, as a result of which you will end up with a limitation of elevation and adduction. Now you can see a typical Brown's, how it looks like this, a limitation of elevation here, and there's a Y pattern there. As the eyes are going up because of the tight superior oblique, the eye slips and then you get a divergence in the up case. Now, as you all know, there are two types. One is congenital and the other one is acquired. And in the congenital, you need to take the history for the parents, look at the family album photographs to see if the child has head posture. And then in the acquired ones, typically in this part of the world, you have seen some inflammatory, myositis and some lesions in the muscle causing a Brown syndrome, usually are associated with pain and sometimes intermittent double vision. And typically ask for the head posture in the history. And with regards to the eye motility examination, we need to look at all the versions reductions. And the most important thing is a traction test for the superior oblique, which will be strongly positive because of the tight abnormal short tendon. Sometimes you palpate the trochlea, the intermittent Browns by you palpating and putting pressure, sometimes it gets relieved. And these children tend to have good stereo acuity, but they have a head posture because of a primary position alignment. So whenever they have a head posture, that means the child has a hypertrophy in the primary position. And that's the reason why the child is adopting a head posture, a chin elevation in the face turn. So the indication for surgery is basically a significant face turn. That's the main indication. And if there is no face turn or there's no primary position hypertropia, then generally we do not operate on these Brown syndrome patients. Now, options available surgical, the tenotomy near the insertion, that is the most common ones which are being used as what we call as superior oblique tenotomy or tenectomy, and then tenotomy nasal to the superior rectus. That's between the trochlea and the superior rectus, which is kind of most significant weakening of the superior oblique. Recession has been given up, nobody does it, and then there a spacer where you elongate the tendon by putting a silicone band, which was proposed by Ken Wright. Now, the most important thing to know the traction test, to know the tightness of the superior oblique muscle, we'll just go through this, the traction test, how it is done. You see that you retropulse the globe and you're holding it with two forceps and rocking the eye along the superior orbital margin, and you feel the tightness of the tendon. That's a traction test. And then once you know that, then we kind of, we are opening the superior oblique to superior temporal insertion. And then the conjunctiva and the tenons is retracted, the superior rectus held on the hook, and then with the small iris hook, you go and, those glistening fibers of superior oblique are seen under direct visualization with a small hook. You hook the superior oblique and get the whole muscle out so that you don't miss the posterior 1/3. And this vertex vein is the landmark when you're hooking it, so don't damage the vertex vein. And once you're seen the superior oblique which has come up fully, then see for the tightness in this. And then if it's extremely tight, then we remove a part of the tendon, which we call as a tenectomy. Otherwise, we just do a tenotomy near the insertion and then release it. And after that, you release the superior rectus on the hook under the superior rectus, and then do a traction test and close it. So at the end of the procedure, the traction test should become, it should normalize. That's the end point of the. So see, you do that. See that the eye is elevating, and you don't really feel the tension on the superior oblique. Now again, another traction test. You see, as I'm doing that rocking maneuver along the superior orbital region, you can feel the tightness in the superior oblique tendon. Now, just to show you how it looks, left Brown syndrome, a Y pattern in the up gaze, and post-operatively. Marked limitation of, the limitation is gone, and there is significant improvement of elevation. The Y pattern has collapsed, and then there's no underaction of the superior oblique here after the tenotomy. So he's got a good result in the immediate post-op period, but you need to follow them up in the long run, because some of these patients can develop a iatrogenic weakness of the superior oblique. To kind of take care of the Brown syndrome, sometimes 1/3 of these patients land up with underaction of the superior oblique and a hypertrophy later. Here is a bilateral Brown syndrome. You can see the chin elevation here, marked Y pattern, limitation of elevation here, limitation of elevation in this eye. And then after the tenotomy, you see the collapsed Y there, improved elevation here, and looks pretty good. Good superior oblique function. Okay, but these patients need to be followed up on a long-term basis, because it's been seen that the most recent study done by Sprunger et al. It's been shown that 1/3 of these patients land up with superior oblique palsy. So these patients may need to be tackled as a superior oblique palsy and treated. Now, this is the right tendon spacer which we put here. This is another technique where, on the superior nasal aspect, you expose the tendon, the superior oblique tendon, and then, you can use the sutures and then disinsert the tendon in between, and then and take the silicone band and measure the silicone band, and then pass it through that, and then you insert a silicone band. So that's basically a Wright's procedure. So basically, you're elongating the tendon so that the limitation is released. But the problem with the Wright's tendon is sometimes Wright's procedure is it can cause significant adherence there and extrusion of whatever the material which you have put there, the silicone. You see this Brown syndrome here, left Browns, and day 1, improvement in elevation there, hypertropia, doing good, day 1. Post-op 3 months, doing good still. Good superior oblique function, absolutely normal. And a year later, you start seeing a mild underaction of the superior oblique here, little hypertropia here, vertical, and overaction of the inferior oblique is developing slowly. On the head tilt test, you see a larger left hyper on tilting the head to the left side. Basically, now this patient over a period of time has started developing a superior oblique palsy, which is an iatrogenic one, because of the weakening procedure which we did for Brown syndrome. Now, you need to tackle this superior oblique palsy. We did left inferior oblique myectomy in him and a small inferior rectus recess to balance the eyes, and then he's perfectly aligned. So that's the Brown syndrome. And sometimes, now that's congenital Brown syndrome. Now coming to the acquired Brown syndrome, a little bit about it. You see this limitation of elevation here, sudden onset of limitation of elevation with pain. And you see we did an MRI, and you see a superior oblique cystosarcosis here. So we have reported a series of superior oblique cystosarcosis, which causes Brown syndrome, and you tackle them with albendazole and oral steroids, and you see marked improvement there, and the cyst resolved. And you see on the ultrasound the scolex in the cyst here, and then after treatment here. So that's a congenital Brown syndrome. Then you can see traumatic Brown syndrome. Do you have time, Raman? Another 1 minute?
Yes, sir, please go on.
Do you have time? Yeah. Okay. So this is traumatic Browns, an injury to the trochlear area and causing a limitation of elevation there. This is a cricket ball injury. And then you see on MRI scan, your disruption of the trochlear area. Yeah.
Sir,
Disruption.
sir,
Yeah, Raman. Yeah, that's fine, Raman. Thanks a lot. Okay. I appreciate it. Thank you very much. Thanks for patient hearing. Okay. Yeah.
Sir, thank you so much, sir.
Once again,
Okay, sir, sure.
yeah, I'm audible and I'm visible.
Yes, sir.
Yeah. After those 2 or 3 excellent lectures, I would like to give you some basic tips in sensory and motor evaluation in pediatric strabismus. See, mostly a child is brought to OPD either with a complaint of deviation or diminished vision. Whenever an infant is brought to you, you have to look for the visual acuity of the child. If it is an infant, look for the pupillary reflex first, then see whether he is able to fixate, fix and follow, look for CSM, central, steady and maintain. And these are the different gist of test which can be done according to the age group. And children are very mischievous. Whenever you try to record the visual acuity, they try to see from the top of the trial frame or peep in the gap between the fingers. So your visual recording can be wrong totally. So you should be very careful while recording the visual acuity. And when a child is brought to you like this with the inward deviation, you are in a dilemma whether the visual acuity in the right eye is good or the left eye is good. Then you go for the fixation preference test. What is fixation preference? The child tries to look with the eye which has a better eye. When you close the eye with the left eye, when you close the left eye, when you close the right eye, he doesn't resist. And when you close the left eye, when you close the left eye, he just hand at the target. That is fixation preference. Fixation preference is the child tries to look through the eye which has a good visual acuity. And next, go for next, look for any pseudo deviations. When there is a pupillary distance is small, you can have a false belief that there can be esotropia, or when the pupillary distance is wide, you get a false belief that there is pseudo exotropia. This picture has the child has a typical head tilt to the left, chin depression and face turn to the right. This was a case of left superior oblique palsy. And these 2 children have a face turn to the left. The first child had a DRS of left eye type 1. To compensate and to get some better visual acuity, he is turning his face to the left. And the second child had nystagmus, wherein to get the eyes into the null zone, when he looks to the new version, the nystagmus is increasing. And when he looks to the left, the nystagmus is increasing. Whereas when he looks to the right, the diplopia is decreased or totally absent. That is the null zone. To come into the null zone, he is trying to take that CHP. And this child has bilateral ptosis with ocular movement restriction. And to get a better visual acuity, he is putting his chin up. And look for the facial asymmetry. Facial symmetry that can be measured from a line with a line drawn from the lateral canthus to the angle of the mouth. Though both these children have a right-sided hypoplasia. Look for Marcus gun phenomena, and then look for most important is pseudotosis. When a patient comes like this, you think that it is a ptosis, but when you cover the right eye, the left eye tends to take up the fixation and the lid goes up. This is a pseudotosis. And cover test, coming to cover test, when you the picture on to the left says that the patient is orthotropic, but when you cover the right eye, I've used this Spielman transplant occluder for a better demonstration. the left eye is fixating and the right eye, what is happening to the right eye? The right eye is deviating out, that is exophoria. And this video showing DVD, wherein when you upload the left eye goes up. When you cover the right eye goes up. One eye goes up, when you cover it, the other eye goes up when you cover it. But when you uncover, both eyes tend to move up, where the Hebbing's law is not being followed. This is a typical feature of DVD, that is dissociative vertical deviation. So always use a accommodative target whenever you are trying to do a cover, uncover, or alternate cover test. You always have a doubt whether the deviation is unilateral or alternating. When you cover the right eye, the left eye fixates. When you uncover the right eye, the left eye is continuing to maintain the fixation and the right eye is deviating. When you cover the right eye, the left eye again takes a fixation. This purely says that the deviation is alternating, which does not happen so in case of this patient, wherein the right eye is deviating. When you cover the right eye, left eye, the right eye tends to take a fixation. When you uncover again, immediately the left eye comes and takes a fixation, which is the deviation is unilateral. This is Hirschberg's corneal reflex test, which gives you a rough idea about the deviation. And you do a prism bar cover test always by putting the base away from the side of deviation. Do the assess the deviation both in vertical and down gaze, so that you will be knowing rather than pattern deviations. And you can also do a convergence assessment with a RAF ruler. And when the child has both horizontal and vertical deviations, you are in a dilemma how to measure both horizontal and vertical deviation. First, you neutralize the horizontal deviation, and by putting a vertical prism bar on the opposite eye, you can easily assess the vertical deviation. And this is one more important test, which is Krimsky's test, wherein you see there is a left esotropia, and when you cover the right eye, the left eye is not taking a fixation. And when you put a prism bar, vertical prism bar in front of the right eye, the left eye, the pupillary reflex in the left eye comes to the center, and this gives you the correct amount of deviation in the left eye. And binocular single vision can be assessed either by Watford test or by Differential test or Baglani test, and so on and so forth. Coming to the motor evaluation, when pretty child comes to you like this, you have a doubt whether the deviation is committant or incommittant. You do a Dahlstedt maneuver, turn the face to the right eye is adducting. You have a clear idea that this is purely a committant deviation, which is not happening so in this case, where there is a left inward deviation, and when you turn the head to the right, the left eye is not deviating. So this is an incommitted deviation, and in this, both eyes are not abducting. This is a bilateral DRS with a dermal lipoma, and this is typical DRS type 1 of left eye, where there is a esotropia of the left eye, and when he is looking to the left, the palpebral fissure is widening, and when he is looking to the right, the palpebral fissure is narrowing. DRS type 1. Looking at this child, when the child is looking to the left, the right, when the left eye palpebral fissure is narrowing and the right eye palpebral fissure is widening. When the child is looking to the left, the right eye palpebral fissure is narrowing and the left eye palpebral fissure is widening. Not only that, there is restriction of ocular movement in adduction in both eyes. So this is bilateral DRS. Always look for the inferior oblique overaction. Adductions have to be assessed by closing one eye. And diplopia charting, remember, always try to depict a clear image with a solid line and a false image with a dotted line. If you have a tilt, you show the tilt. These are some of the examples of different rectum muscle palsies. And lastly, coming to Hess charting, where the child is made to sit in front of a Hess chart and is given a green light, laser light. Just 1 minute, just 1 minute. He is given a green light, and this mainly depends upon the haploscopic principle, where the child putting on the red-green light, he can superimpose. So these are some of the examples of Hess chart. And thank you everyone for giving me thank you, Chairman sir, for giving me this opportunity. Thank you.
I request Dr. Anjali to take over the session.
Good afternoon, everyone. At the outset, I would like to thank Dr. Raman sir and the TOS team for giving me the opportunity to present. I'll be talking on how to manage pattern strabismus in a child. So what is pattern strabismus? Whenever the horizontal deviation becomes incomitant in vertical gaze, that is when the child looks from up to down and there is a difference in the amount of deviation, that becomes a pattern. It is a very common association. It is seen in many types of strabismus, especially in infantile esotropes and intermittent exotropia, and has a prevalence ranging from 12 to 50%. Why is it important? Missed patterns can give suboptimal treatment outcomes. That is why it is important to know and to understand how to measure a pattern. There are many types of this. The common types are the A and V pattern, as we know, and V exotropia is the commonest of the lot. There are some other types like Y, X, lambda, arrow, and diamond, of which Y and X are commoner. So what is an A pattern? A pattern happens when there is a relative convergence in up gaze and a divergence in down gaze, mimicking the alphabet A. And the difference in prism diopters we take as 10 prism diopters between up and down. Like here, this is a case of an A esotropia where the eye is converging up and diverging down. And by the measurement, we can make out there is a significant 30 prism diopters of difference. This is A exotropia, where there is a convergence up and the exotropia worsens in down gaze. And again, there is a significant difference between the up and down of more than 25. V pattern, it is where there's a relative divergence on up gaze and it converges in down gaze, mimicking the alphabet V. Can we mute the other speakers? There's a minimum difference of 15 prism diopters for a V pattern, which is slightly more than for the A pattern. So it's a case of V esotropia, where there is a esotropia is more in down gaze and esotropia is less in up gaze, and the difference of 20 PD. Similarly, V exo, there is exotropia more in up gaze and exo is down, less in down. That is a V exo with a significant difference. Just like Dr. BVR sir was showing, Brown syndrome, especially bilateral Brown syndrome, can cause something called as a Y pattern, where there is a CCDD, like there is a divergence in up gaze, very minimal deviation in primary and same amount of deviation as in primary as in down gaze. So mimicking the alphabet Y. X pattern happens when there is a large angle of deviation in the up and down gaze, mimicking the letter X, because of a tight lateral rectus in large angle strabismus. And that is also, it will cause a pseudo oblique overaction. There's no true oblique overaction here. So what is also important to remember is while measuring, we should not miss cases, overdiagnose the case. So if you have cases of accommodative esotropia where the hyperopic error has not been corrected, and if we measure the child in down gaze, then it will look like a pseudo V. So all the corrections have to be done with the glass, with the spectacle correction in place, all the measurements. And pseudo V exotropia can happen if there is an intermittent exotropia where there is no fixation target at distance, then the child breaks the fusion for primary and up gaze and fuses for down. So that can cause a pseudo V. So pathophysiology is because of central and peripheral causes. I'll cover the peripheral causes first. It is of historical importance that horizontal rectus and cyclovertical muscle dysfunction was causing pattern. Now, the more common theories are oblique muscle dysfunction, extraocular muscle pulley dysfunction, and orbital anomalies. So the oblique school, which is popularized by Knapp's, it says that there is an inferior oblique overaction, which is responsible for a V pattern. And the current denotion is over elevation in adduction. So inferior oblique overaction is causing over elevation and adduction, and that causes a V pattern. Similarly, superior oblique overaction causes a over depression in adduction, and it causes divergence of the eyes in down gaze, and that causes A pattern. So over elevation in adduction and over depression in adduction. So we can see the 9-gaze picture here of a patient with V exo with a bilateral inferior oblique overaction. And this is a case of an A pattern exo with over depression adduction because of superior oblique overaction. What are the orbital factors which can cause? These are usually orbitofacial anomalies like plagiocephaly, hydrocephalus, and the craniosynostosis like Cruzens and Apperts. This is a child, the picture over here, you can see there is a flattening of the forehead on the right side and there is a bulging onto the other side. This is because of premature fusion of the lambdoid sutures, and this causes retroplacement of the trochlea. And it mimics a pseudoparesis of the superior oblique. It looks like there is a palsy of the superior oblique, but it's not a true palsy. It's because of the shortening of the tendon of the superior oblique because of the positioning of the trochlea. Similarly, hydrocephalus, it causes forward placement of the trochlea because of bossing of the skull, and that causes mimics an overaction of the superior oblique muscle, and these can induce patterns. Cruzen's and Apert syndrome, it is not because of the orbital orbital anomaly as such, it's because of anomalous extraocular muscle pathways, anomalous extraocular bands or pulleys, which can cause a V pattern exotropia, and usually there's no true overaction of muscles in these cases. Another theory popularized by Dr. Diemer was the extraocular muscle pulley heterotropy. So not only we have extraocular muscles, but the posterior tenons capsule, it fuses to form a sheet around the muscles, which act like a muscle pulley. And the displacement of that muscle pulley can lead to V pattern exotropia. There are many central causes. Loss of fusion, supranuclear anomalies, vestibular anomalies are also known. Like because of loss of fusion, there can be a torsional drift of the eyes, causing excyclotorsion, and that can alter the position of the rectus muscles, and that can mimic an oblique overaction. Similarly, vestibular dysfunction, and because of neurological causes like hydrocephalus, spina bifida, that can cause dysfunction of the semicircular canals, and this is thought to mimic a special form of skew deviation, and A pattern is common in these cases. So coming to the most important aspect, history and examination. As a regular strabismus case, we need to take the history and the examination, as was shown by the previous speaker. And here to point to notice, to look at abnormal head posture, Prism cover test, at least in the cardinal positions of gaze, and quantification of the oblique muscle actions. So here we can see this child with a Y pattern exo. There's a chin up posture. That is because she is fusing better in the down gaze. So chin elevation is common in V exo and A exo. Chin depression is common in V exo and A exo. It's a challenge to examine ocular motility in a small child. We need to use attractive fixation targets or do a Dahl's maneuver. Like this child with a large angle infantile exo, if we do not actually assess the complete motility, we would miss the inferior oblique overaction. And also it is important to know when there is an inferior oblique overaction, suppose you notice that there is a significant underaction of the SO, that may be a case of a bilateral congenital SO palsy. So how do we measure? The easier way to measure is actually by doing the Prism cover test by tilting the patient's head down and up, rather than moving the fixation targets up and down. And it is a clue to also know that there is an oblique overaction is to look for the cover test in adduction, also called as a cross cover test, and look for any hyper or hypotropias. Also, we need to document oblique muscle overaction as +1 to +4 or -1 to -4, depending on the position of the limbus here. We can note that. So can I continue? The very important aspect to note is in the fundus examination to look for excyclotorsion and encyclotorsion. Encyclotorsion mimics is because of superior oblique overaction. Excyclotorsion is because of inferior oblique overaction. Sometimes even more than versions, the torsion of the fundus gives us a clue that there is a pattern. The surgical management need not correct all the cases, but wherever the deviation is interfering with the binocular single vision, or there is an AHP, then we need to consider the correction, and we should consider the functional positions of gaze, that is primary and down gaze for the correction. The brief guidelines is if there is an oblique overaction, you weaken the obliques with the horizontal rectus. If there is no oblique overaction, then you tackle only the horizontal rectus by doing a upshift or a downshift. IO weakening procedures, many of them are there. We normally prefer recession of the inferior oblique if there is no DVD. If there is a DVD, we go for a IOAT or IONT. Like here, we can see the position of the inferior oblique, how it has been, how it's positioned behind the inferior rectus. So this is an example of a 4-year-old girl with V pattern exo with a bilateral 2+ inferior oblique overaction. So in this case, we have done a bilateral MR recession with an IO recession, and that has caused a autotropia and a pattern collapse. Similarly, here this is a case of V exo with IO overaction, and we have done a V both sides LR recession with IO, and that has caused a good outcome. Whenever there is a DVD, go for an IO inferior oblique anterior transposition.
Sorry.
Yeah.
Time up, ma'am.
Okay. Okay. So patterns are basically common and multifactorial causes there. Recognizing it is important. Recognizing the pattern is important. If there's an oblique muscle overaction, correct that. If there is no oblique overaction, then transpose the horizontal muscles. Thank you.
Thank you, Amma.
I request Dr. Diraksha to do the presentation.
Okay, can I start?
Yes, ma'am.
Yeah. Good afternoon. Today's topic for presentation is acute acquired comitant esotropia. Acute acquired comitant esotropia is an unusual presentation that occurs in older children and adults. Burian classified it into 3 types depending upon the underlying etiology. But the common characteristics for all of them are acute onset, comitance for both near and distance, relatively large angle of deviation, diplopia, good binocular potential, and lack of any underlying neurological disease. Now coming to first type 1 SWAN type, this form of strabismus occurs basically after monocular occlusion or after monocular or asymmetric visual loss. Monocular occlusion means usually after prolonged occlusion for a amblyopia therapy or following major or minor surgical intervention. So it appears therefore that this monocular occlusion or the visual loss has resulted in the disruption of the fusion, following which the latent deviation has become manifest. In type 2 or the Burian-Franchetti type, initially the patient presents with esotropia, which is intermittent, but it quickly becomes constant. There is minimal hyperopia with no accommodative component, and usually it occurs spontaneously, but in some children we have seen that debilitating illness, physical or psychological stress may precede the onset of the deviation. And in type 3 or the Belchowski type, they have a myopic refractive error, initially presenting with a small angle esotropia, but later on it gradually develops into a large angle type. Now, usually the acute acquired comitant esotropia, it is usually benign, but in some cases it occurs along with some neurological disorders like the posterior fossa tumors or hydrocephalus, GRE type 1 malformation, thalamic disease, or idiopathic intracranial hypertension, myasthenia gravis. So in these cases, appropriate neuroradiological approach is warranted. Differential diagnosis include divergence paralysis and bilateral 6th nerve palsy. And the non-surgical and the surgical, good binocular and the functional outcome can be achieved with non-surgical as well as surgical management. Non-surgical includes the correction of the underlying refractive error, prisms, that is base out prisms, and chemodenervation. So, and also the correction of the underlying neurological cause has to be done. Now, coming to the cases, we'll be presenting few cases. In case 1, a 10-year-old boy presented with chief complaints of inward deviation of the left eye since 2 months, sudden in onset associated with headache. And when we had taken his thorough history, we came to know that he was diagnosed with TB meningitis 2 months back and started on ATT. On orthoptic evaluation, PBCT was 30% diagnosed for both near and distance. And this is the 9-gaze pictures with extraocular movements full and free. And this is his fundus photographs showing both eyes grade 2 papilledema. And MRI was done, which showed that he had a solid caseating tuberculous granuloma. So obviously this was the underlying neurological etiology for this acute acquired esotropia. Since the boy is on ATT and we'll be doing regular follow-up, and we had done, and after 6 months we'll be evaluating again, and the residual stable ESO deviation will be surgically corrected. Now the second case, a 13-year-old boy presented with chief complaints of inward deviation of the left eye associated with headache. His best corrected visual acuity was 6/6 in both eyes, and on orthoptic evaluation, PBCT was 45 prism diopters in both eyes for near and distance. This is the 9-gaze pictures, which shows that extraocular movements are full and free. Neuroimaging was done and with no abnormality detected. He was treated surgically. He had undergone both eyes MR recession. Post-surgically, he attained orthotropia, and with good motor and sensory fusion was also attained. In the next case, a 9-year-old female child presented with complaints of inward deviation of right eye since 6 months associated with diplopia, which worsened during evening. Her best corrected visual acuity is 6/6. This is her orthoptic evaluation. Okay, and these are the 9-gaze pictures. And this is no change in deviation with the glasses was noted. As the patient had diplopia, which worsened during evening, we suspected ocular myasthenia gravis and advised neurophysician opinion. She had undergone tests like the CT chest, which showed an enlarged thymus, and also a single fiber EMG, which was confirmatory of ocular myasthenia gravis. In spite of her medical treatment with cholinesterase inhibitors and steroids, the deviation persisted, and we took her up for surgery after 6 months. This is her post-op picture, orthotopia with good functional outcome. In yet another case of a 14-year-old boy, presented with to us with complaints of double vision and inward deviation. Comprehensive ophthalmic and orthoptic evaluation was done. Refraction was done, and with in right eye with -3, he was improving to 6/6, and left eye -2 diasperical, he was improving to 6/6. And this, when we had given him this refractive error, it resulted in orthotropia and relief in diplopia. And thus, in this is a picture that is, we can see that deviation without glasses and with the glasses also. So in this case, conservatively, we had managed this case. So the take-home point in this is that high index of suspicion should be maintained and neuroimaging should be done, because in some cases, acute acquired comitant esotropia is the only presenting feature. And if no other neurological signs are present, then underlying neurological disorder is unlikely. And moreover, good motor and sensory outcomes can be achieved with both surgical as well as non-surgical methods. Thank you. And I also thank Dr. Raman and Dr. Krishna Kishore sir for giving me this opportunity for speaking. Thank you.
We have 7 minutes for discussion.
Anything to be added? Anything to be added, sir?
I think that's very nice presentations by all of them. Like the acute onset esotropia and the presentation by Anjali on the pattern deviations. So I think that, and the sensory evaluation by Dr. Krishna Kumar sir was pretty good. Yeah, a lot of information there. Yeah. So normally, acute concomitant esotropia, I really do not know whether myasthenia can be put into a category of acute.
But actually, what happened? No?
Yeah.
Initially we had the doubt, sir.
Yeah.
Because there was a diurnal variation, especially.
Right.
The
Right.
child was complaining. In the
Right.
evening time, the diplopia was worsening. So we referred the patient to the neurophysician at Lesions.
Correct. Yeah.
They evaluated, sir.
Right.
So later,
So
the patient was put on medical treatment.
Correct.
But subsequently, there was no resolution of the symptoms. We waited for 6 months.
Yeah.
No,
so yeah, so that's pretty valid enough. Basically, in the sense that the myasthenic ones are to be classified differently, not into the category of acute concomitant acquired esotropias.
Yeah.
So that's a myasthenic kind of a problem. It can present with esotropia. It could present with anything.
Yes.
So I think that should be separated out from the acute concomitant ones. Yeah. But otherwise, pretty valid enough.
Rare possibility, sir.
Yes. Yeah.
Initially, we had the suspicion, but later on in subsequent stages,
correct. Yeah.
We excluded that possibility.
Right.
It was taken for surgery and
right.
child was orthotropic.
Very nice. Yeah. Any questions from the audience participants? Have they sent out any questions?
No, sir. No questions.
No, the panels, no. Oh, okay. So, okay, fine. Yeah. So, Anjali.
Yes, sir.
Anjali.
Yeah, just kind of the pattern strabismus, right? Yeah. So, what are the weakening procedures which you are doing for inferior obliques?
So,
which is your choice?
If there is no dissociated, no DVD, then I usually go for recession.
Okay.
And I look at the amount of the oblique overaction,
Right.
and then decide based on also the traction test.
Okay.
So I decide the parks or the Shice point based on that.
Okay.
If there is a DVD, then definitely I go for the inferior-oblique transposition,
Anti-transposition.
anti-transposition. But
So you
even
do-
after that, sometimes
Mhm.
some of the DVD actually still remains. It's not totally gone.
Right. Yeah. I know. Yeah, that's right. Because DVD is a difficult entity. You never can get away with DVD. You still have some amount of trace DVDs can be present. Sometimes, during testing time, it might, sometimes they may not. So you can actually lessen the DVD significantly, not eliminate it. That's the basic idea. So I do myectomies pretty well. You do recession, that's good enough. Whichever way it works, I think that should do good. Okay. Yeah.
And we can go for even inferior-oblique graded recessions we can try.
Yeah, you could do that, graded recessions. Yeah. So yeah, for the inferior oblique anti-transposition, one thing would be that don't do it unilaterally. Always try to do bilateral inferior oblique anti-transposition, because if you do one eye unilateral inferior oblique anti-transposition, sooner than later, other eye will start. Other eye also will start elevating it. And then depending on the DVD, then you grade your inferior oblique anti-transposition, how much you want to put anterior to the inferior rectus, whether 1 millimeter, 2 millimeters, or 3 millimeters. So based on that, you do the work. Yeah, good. So third node palsy, Dr. Raman, you're doing what? Which kind of procedures are you doing right now?
Actually, in that cases two I presented, no?
Yeah.
There was a vertical hypertropia.
Okay.
In one case, there was a FDT was positive.
Right.
In the other case, it was negative with -1 adduction deficiency. In one case, there was a pseudotosis with 2 ptosis. In the other case, there was only pseudotosis. So here I did a lateral rectus full tendon transposition.
Okay. To the superior rectus. Okay, right.
Lateral rectus full tendon transposition to superior rectus, and I applied augmented faster suture.
Okay.
So then away from the superior rectus tendinous insertion.
Right.
So it has resulted in you have seen almost like a deviation of.
Absolutely. Yeah. Right.
That was probably maybe novel. Actually, in the previous, in literature, described the inferior rectus resection combined with superior rectus resection was a discussion, but I tried a different way. And for large exodeviations, usually I plan for a supramarginal lateral rectus resection with MR resection. And when in failed cases, usually I go for LR periosteal fixation.
Okay, periosteal fixation. So did you try the medial plication to the medial rectus?
No, sir. Plication I never.
No.
But I did
to the MPL, the palpebral ligament.
Yeah, sir. No, sir. I never tried.
Okay.
I tried only these two procedures, but in some cases, whenever there is an aberrant regeneration,
right,
especially if the aberrant in the misfiring is going to the inferior rectus, if it is strengthened, I did even few cases the transposition, inferior rectus transposition to the medial rectus muscle.
Oh, okay.
I did, but not the superior oblique transposition or the lateral rectus split and transposition.
So the other thing which works well in that exotropic third nerve would be a lateral rectus, split lateral rectus, transposing both arms of the split lateral rectus towards the medial rectus. Okay, that works well. At the same time,
we are waiting for the opportunity, sir.
Yeah. Yeah, Ramesh, how are you?
Ramesh is not on the line.
I'm fine.
Oh, he is
fine. I'm very much here.
Good.
Yeah.
Good. Nystagmus is.
Yeah.
Yeah.
He's not seen. Oh, now he is.
I'm here, Dr. Raman. Yeah.
Thank you.
Right.
Our session is come to end. Thank you very much.
Yeah, thank you all.
Thank you.
I thank all the speakers for the wonderful session.